Good morning. Today's class is on dental amalgam. So the topic will be covered under the following headings of introduction: history of amalgam, amalgam wars, its classification, the components of amalgam, the manufacture of alloy powder, its basic setting reaction, manipulation of amalgam, the properties of amalgam, recent advances in amalgam, mercury poisoning, as well as its conclusion. So dental amalgam is one of the most versatile restorative materials used in dentistry. It constitutes approximately 75% of all restorative materials used by the dentist. It has served as a dental restoration for more than 165 years. So the advantages of amalgam is that it is less technique sensitive, it has acceptable biocompatibility, it is cost effective and has a long life. This has led to the popularity of amalgam among the dental practitioners. However, over the last few years, improvements in its composition have led to a reduced marginal failure due to decreased creep and corrosion, and an early seal between the tooth and the restorative interface. But developments of alternate ceramics and composites and questions on the safety of amalgam have led to the decline in its use. So the next question is, what is amalgam? So amalgam is defined as any alloy of mercury with any other metal. The word amalgam is derived from the Greek name emolian, which means paste. The dental amalgam is an alloy made by mixing mercury with a silver tin amalgam alloy. So amalgam alloy is a silver tin alloy to which varying amounts of copper and small amounts of zinc have been added. Coming to the indications of amalgam. So amalgam is generally indicated to moderate to large class 1 and class 2 restorations. They are also used in class 5 restorations in anesthetic areas. So amalgam restorations are generally contraindicated because of its poor aesthetics. It's not indicated in small defects in the posterior teeth and when there is a requirement for reinforcement of the tooth. The advantages which make amalgam popular are its ease of handling, its high compressive strength, it has excellent wear resistance, it has favorable long-term clinical results, and it has lower cost when compared to composite restorations. The disadvantages are that it is anesthetic, it is non-insulating, it is less conservative in the removal of tooth structure, it weakens the tooth structure, it requires a specific tooth preparation, there is initial marginal leakage, and it does not bond to the tooth structure. Coming to the history of amalgam, in 1818, Louis Nicholas Regnat, a Parisian physician, invented amalgam by the addition of 1/10 by weight of mercury to other material. Dental silver amalgam was probably introduced in England by Joseph Bell, a British chemist, in 1819 and was known as Bell's putty. Traveau described its silver paste filling material in 1826. He produced amalgam by mixing the silver coins with mercury. In 1833, the Crocus brothers introduced to America their Royal Mineral Succedaneum, which was actually shaved French silver coins and mercury. Amalgam's dispute initiated by these brothers led to the Amalgam War and to the promulgation by the American Society of Dental Surgeons in 1845. Coming to the Amalgam Wars, the first Amalgam War was initiated in 1845 by the American Society of Dental Surgeons, which condemned the use of all filling materials other than gold as toxics, thereby igniting the first Amalgam War. So what led to the end of the Amalgam War? The factors which led to the end of the war were professional and consumer demand. Between 1860 and 1890, many experiments were done to improve amalgam fillings and materials. It was a classical work of Dr. G.B. Black in 1895 that a systemic study was done on the properties and appropriate manipulation of amalgam. The end of the first amalgam war led to the beginning of the second amalgam war. This started as controversy over amalgam use resurfaced again in 1926 and into the 1930s when a German physician named Alfred Strock showed that mercury escaped from the fillings in the form of a dangerous vapor that could cause significant medical damage. During this second amalgam war, the American Dental Association vigorously defended silver amalgam and its widespread use was continued. The third amalgam war took place in the 1980s. It was the neurobiologist Max Hansen in 1981 who started the fight against the authorities. But the ADA remained adamant that mercury in a patient's mouth is safe, and in 1986 it changed its code of ethics, making it unethical for a dentist to recommend the removal of amalgam because of mercury. The universal acceptance of amalgam as a restorative material resulted from investigations of G.B. Black in 1895, 1896, and 1908. By combining the principles of cavity design and the development of an alloy with the composition of 68.5% silver, 25% tin, 5% gold, and 1% zinc, Black advanced amalgam into modern times. SS White manufactured the first commercial amalgam alloy, which is rich in silver. True Dent alloy was manufactured in 1900, in which gold was replaced by copper. The ADA specification number 1 was adapted for amalgam in 1929. Coming to the classification of amalgam, according to the number of alloyed metals, amalgam can be classified as binary alloy, where there are 2 alloyed metals, tertiary alloy, and quaternary alloy. According to the shape of the powder particles, amalgam can be classified as lathe cut, spherical, and admixed. According to the copper content, amalgam is classified as low copper amalgam, which consists of less than 6% of copper, and high copper amalgam, where there is 6 to 13% of copper content. According to the zinc content, amalgam can be classified as zinc containing alloy, where there is greater than 0.1 to 2% zinc, or non-zinc containing alloy, which is a zinc-free alloy. According to the particle size, this is the classification for amalgam. So amalgam can also be classified according to the generations based on improvement in its composition. The first generation consists of silver and tin. The second generation consists of silver and tin as well as copper and zinc. The third generation has the conventional silver tin alloy to which the Ag3Cu is added. The fourth generation, which is a combination of silver, tin, and copper up to 29%. In the fifth generation, there is silver, tin, copper, and indium, which is a quaternary alloy. Coming to the components of dental amalgam, the basic components include the silver, mercury, tin, and copper. The other components of amalgam include zinc, indium, and palladium. So talking about the individual components will be done in the next following classes. Thank you.